Working quietly behind the scenes, the Care 24/7 team has been investigating ways of providing integrated, seamless care to patients across all our hospital sites. One of the priorities identified by the team has been the formalisation of the clinical handover process between teams and shifts. But what does this formalisation process involve? How can it make care more consistent and safe? What impact does it have for staff?
Patients don't come to the hospital between 9 o'clock in the morning and 5 o'clock at night. They're coming 24 hours a day, 7 days a week. And the people that meet them in the front line tend to be the junior doctors, nurses and allied healthcare professionals. And so we needed a system to ensure that we were operating consistently across the 24 hours period. Failure in handover has been recognised as a major preventable cause of patient harm, and it's principally due to human factors of poor communication, and these lead to systemic errors in patient care.
Clinical handover is one of the most dangerous times in the care of a patient in any environment. So addressing handover in a robust way is really essential in delivering safe and high quality care.
We need to provide 24/7 safe care, and that's what we provide. If all the team is singing from the same song sheet, we know what's going across the site, then we can provide excellent care.
The more we know about the patient, the more we can help them, and the less chance of us missing essential piece of information.
It's preventing those crises occurring in the middle of the night. All the patients who are potentially vulnerable we're aware of, and there's a plan. And so things are much more controlled and ordered.
Central to the successful change to clinical handover is the use of a standardised clinical communication tool, SBAR. But what is SBAR? How does it work? What benefits can a standardised clinical communication tool bring to staff and the handover process?
SBAR is an easy to remember, simple tool which formalises the sort of information that need to be drawn to the attention of a doctor. It's a very simple tool which allows people to communicate effectively in high-risk environments. It was developed by the military and it was taken on by the Americans, Kaiser Permanente, and they noticed a 50% drop in patient errors when they implemented SBAR. So we're hoping to replicate that here in Oxford.
Well, it offers us the opportunity of a structured handover. So there's a clear sort of formula to follow.
So I think that SBAR help us run things more smoothly, and get the information across to the other member of the team more efficiently.
The SBAR tool is really useful because one of the issues that we wanted to try and avoid was dealing with more patients in the meeting, but we didn't want the meeting to get too long or to get any longer than it already was. So in making the presentations about each patient crisper and more concise, using the SBAR tool, we've managed to get through more patients in the same time.
I think SBAR is about establishing a common language. It's obvious, I think, that if we don't have that, then we have a medical equivalent of the Tower of Babel, really, with different people trying to communicate concerns about patients or issues that need to be addressed in ways that the other person does not understand properly. SBAR gives us that absolutely common language and common platform to transmit that information.
Formalising the handover process using clinical communication tools seems to bring benefit to both staff and patients. But what are the changes like? What impact do they have on staff? Can formalisation empower staff and ensure that their concerns are heard?
In the evening, switch will bleep all the core members of the team. The bleeps are a really good prompt to get the attendance up, and we've seen the attendance improve a lot since we've introduced the bleeping system.
We have the MDT meeting at 9:30. The handover is given on the patients that have come through on that day's take. My handover process role really varies. Immediately we go in and we have the handover of the patients. Prior to that, I've already done a round around the hospital identifying any patients that the nurses are concerned with, but my main thought, I think, at the handover meeting is to identify patients that haven't been identified by the doctors already or that the nurses have called the doctors to see.
We go through the list. There is a take list for today, and then go through each patient, each and every one, and then also the juniors, the SHOs and F1s who cover the wards, and they usually hand over the sick patients that the night team needs to be aware of. They need to be handed over very carefully because we need to prioritize people in level of their sickness.
We've now added in a systematic review of all the patients that are at risk on the ward, and we get advance warning of the patients that are deteriorating, and we can actually proactively jump in and say, well, actually we need to go and see that person and maybe take them round to critical care.
Everybody involved seems to have a positive reaction to the changes to clinical handover. But why should all staff get involved and push for handover to be formalised across all our hospitals? Can changes to handover really increase patient safety and even reduce staff workload?
By doing it on a formal basis, everybody's bought into it, i.e. they all turn up, they know that it will happen, and they know that all the patients are discussed. In the handover meeting, everybody feels that they're able to voice their concerns, ask questions. Everybody feels comfortable to speak.
I think we're providing great support to the team, and I think patients are being identified before they get to that acute stage where it's acute quick care that's needed. We're identifying patients before they get to that crash stage.
The patients who are not doing well on the wards are identified early on, and they get reviewed promptly, and that can help to improve their overall well-being. The patients are seen by members of the team who have had the opportunity to discuss them in advance. The potential treatment has already been commented upon, discussed, and so when they're seen by whichever member of the team, the likelihood of a good outcome is increased.
The occasions when patients deteriorate unexpectedly, out of hours in particular, and then are found to have had problems that were identified previously but had not been acted on following a handover, will become a thing of the past.
As we have patient safety at the heart of everything we do, getting this right is really important for the whole of the organisation. It'll also lead to efficiencies of time. We use our time, which is precious, much more efficiently, because we'll do less unnecessary investigations, less incorrect treatments, and so on and so forth. So I think for the organisation as a whole, this process can only lead to strategic benefits.
Because if we can prevent things from happening, obviously then we're providing safe 24/7 care for the patient, and that's our ultimate aim.
I think this is a critical part of what we do. We know we've got to provide safe, reliable, high quality care to patients at all times of the day and night. That's a key element of our Delivering Compassionate Excellence mission, and I'm confident that staff, once they recognise that, will really embrace this.